Hey everybody, welcome back to the ECG channel. My name is Reed, and don't forget that you can get the PDF document of today's ECG down to the description below. And don't forget to like this video and subscribe to the channel if you enjoy the content. So let's jump into it. So first thing we got to notice is this is not a traditional 12-lead ECG. This is a Holter monitor. You'll see Holter monitors kind of intermingled throughout some of my videos, and the reason why is because I want you to remember that the ECG is just a snapshot in time, right? It's a 10-second clip of what the heart's doing. So this patient, you're evaluating their symptoms, you're trying to figure out what's causing their lightheadedness or their chest pain or whatever. A Holter monitor can be great because we can do this up to 14 days maybe, right? Depending on how long you think you need to have this person wear it to capture the event that you want. If they're having daily episodes, then maybe just a couple days. And so it'll record these rhythms, and I think they're really helpful because they can help us kind of tease out maybe some of the physiology that we're dealing with. And so this is a great example here. All three of these rhythms here are continuous, and so they kind of just scroll through together. And so let's kind of evaluate what we have going on here. So at first what we have is we've got a narrow complex rhythm. You can see it's kind of tacking along at a pretty regular rate. We've got P waves in front of our QRSs, so that makes me happy. And the rate of these is about 300, 150, 100, 75, 60. It's maybe 59, I'm going to say 59 beats per minute. We've got nice PR intervals right here that are normal, right? We know our PR needs to be less than 200 milliseconds, but also greater than 120 milliseconds, right? That's in between 120 and 200. And so then we notice that as we scroll through, that as we look through this way, we get slowing of this rate. And so what makes you think of slowing of the rate? Well, we know that with inspiration and expiration, we actually can change the parasympathetic tone, and that's based off of blood return and changes in intrathoracic pressure. If you want to learn a little bit more about that, I've got a video on sinus arrhythmia, which is essentially just a normal variation of sinus node rate. And so we can see that in the first two beats, right? You can see that as we slow down, there's some slowing in this beat. We've got a nice P wave that conducts to the QRS. And then this beat gets even a little bit more slower, right? The rate in between these ones are 300, 150, 100, 75, 60, 50, maybe around 40 beats per minute in this beat here. We've got this nice sinus P wave that's conducting to the QRS. And so we see sinus arrhythmia as this person is probably getting a nice big breath. And then what we notice is as it gets even slower, this next beat, look at what happens. This even gets slower than before. And look at the PR interval. My PR interval shortens. So my PR shortens. So what is going on? Well, we know that the PR interval in this person is right around maybe 4 big boxes. So the PR interval for this patient is about 160 milliseconds. So their AV node takes 160 milliseconds to beat. And so in a nice healthy patient, right, we get the SA node firing off, depolarizing through the atria. The AV node is capturing that signal and it delays, right? That's where it's delaying that signal by 160 milliseconds in this patient. That was terrible handwriting. So by 160 milliseconds they delay this. But notice that what we're seeing here is that now we have a PR interval that's shortening. We know the AV node doesn't just get really good all of a sudden, right? It just stays the same. And so what is actually happening in this patient, if you look at the next beats, there's not even a P wave. There's no P waves through these beats, and look how slow they're going, right? So we're maintaining a very slow rate. If I calculate the rate from this to this, maybe that's 300, 150, 100, 75, 60, 50, right? We're still back in the 40s, right? So what is actually happening is this person is a healthy person, and when they inhale and exhale with the changes of their heart rate, their sinus node is slowing down. We have evidence of their sinus node slowing down. And we know that we actually have pacemaker possibilities here at the AV junction. We can have something called a junctional escape. And we know junctional escapes, usually their intrinsic rhythm or rate is 40 to 60 beats per minute. And so what is actually happening here is when this person's sinus beats drop below their pacing ability by their AV junction, you actually see evidence of their junctional escape beats. And that happens for a few beats, right, as this person is taking a big breath in and out. And so the changes in their intrathoracic pressure is causing their heartbeat to slow down. Their sinus node slows down for, however long this is, 5 or 6 seconds. And then whenever that changes back, and you see that we're slowly getting the sinus node is coming back into play, right? And that sinus rate picks back up, and now we have a P wave that appears to be conducting to our QRS in a normal fashion. So that's what's happening here. We're seeing just normal, this is normal cardiac physiology, right? And obviously, given the clinical scenario, if this was an 89-year-old patient who was passing out during these episodes, right, if they clicked the button, well, maybe 40 beats per minute for them is not the answer, right? And we need to get them a pacemaker in their atria. But if this is a young, healthy patient that is asymptomatic and they're sleeping when they have really high vagal tone, then this certainly wouldn't be a problem, right? And if this is not associated with that young patient's symptoms, then great. We can, give them a firm handshake. This is very common in people that are just really good athletes. And so, yeah, that's what we see here. So I hope this helps you understand just good physiology. And if you have any questions about this rhythm, feel free to throw them down into the comments. I think that it's just good to understand what is happening, and so you correlate that to that anatomy and electrophysiology to potential symptomatology, and then you can make great decisions. So I hope this helps. Like I said, feel free to throw your questions down into the comments, and thank you all for watching these videos. We'll see you next time. Have a great day.